and I can see you are so excited to hear, and you're also very hungry. So I'll make sure we finish on time so that you can all have your food. But first of all, I'd like to thank organizers for having me here, and I'm really thoroughly enjoying my time, and particular thanks to Professor Akram. Where he was in the UK, we got chatting about it, and we realized that this is a mutual area of interest that we should all talk about, and hence I'm here today. So let's start by talking about Abil. Now, Abil has a young onset diabetes, nothing unusual. We all see this sort of patients. He's got diabetes age 20. His BMI is 21, and his HbA1c is 7%. If you are very good, you manage to monitor his ketones, and it was 1+. What Abil had, his mom and his grandmother also had diabetes, and if you ask a little bit more about it, his mom was slim, and she diagnosed age 30 and was treated on insulin. So this is nothing unusual. I'm sure you come across these patients. And then the question really is, what type of diabetes Abil has? Is it type 1? Is it type 2? Or is it, you know what, I'm not quite sure. So it really matters what type of diabetes he's got. Because if he's got type 1 diabetes, we know he's got a very severe insulin deficiency. He would require insulin for his life, and he would require it for survival. So you cannot just simply stop it. But the way you replace insulin is also very important. You can't just give them twice a day basal insulin. He would require multiple basal bolus insulin. He needs to change the insulin dose based on what he eats. He would require continuous glucose monitoring and possibly pump if you have access to it. And you need to use some newer insulins for it. You also know that you can't give him metformin. You can't give him sulfonylurea. It's just a useless waste of medication for type 1 diabetes. And you also know he's got very high hypoglycemic risk. So it's important we diagnose the right subtype. If he's got type 2 diabetes, we know he's got relative insulin deficiency. He does not require insulin for survival. You can have a very simple regime of twice a day or basal insulin. And he would definitely benefit by oral therapies or injectable non-insulin therapies. There is no or very little risk of hypoglycemia. But really, recently, now we know that actually you can remit diabetes by having extreme weight loss. So it's important. And finally, something else, no one knows, you don't know, and really the management depends upon individual person, however you think about it. And I hope I'll convince you by the end of this talk that it really matters what type of diabetes people have rather than just saying it's diabetes. And you know, the problem with the field is that we as a diabetologist to blame. Because what we have done is that, type 1 diabetes is very simple. You know what? Young and slim, they have a high glucose. That's type 1. You don't need to think much about it. If they are type 2 diabetes, oh yeah, they're likely to be older and they will be obese, and it's type 2 diabetes. And something else, well, it's up to you, how comfortable you are. For you, it's atypical diabetes. Some people are right in the middle of it or overlapping symptoms. And this is the problem. And because of that, the misclassification is very high. So we show in Exeter that actually 30% of type 1 diabetes are misdiagnosed. 50% of type 2 diabetes are initially treated with insulin. So misclassification is really high. And the problem with the field of diabetes is that we don't like to measure hormones. We are hormone doctors. You have a thyroid disease, you would measure thyroid hormone. You have an adrenal disease, you measure adrenal hormone. Even the cardiologists, who are the worst of medical doctors, hey Usman, they measure heart markers when they have the heart disease. You know what we do with diabetes? We don't measure any hormones. We just say glucose, diabetes. Type 1, because I think they are slim. And actually, that's not true. We do have access to very cheaper biomarkers. The one is C-peptide. You can measure how much person is making insulin. And you also have access to Islet autoantibodies. So we do have a biomarkers, but we actually don't like to measure it because we think, as a diabetologist, that we know the best. I don't need biomarkers. So let me tell you about the biomarkers. So there are Islet autoantibodies. If you haven't measured it, do measure it. There are about 3 most common type of it, IA2A, ZNT8, and GAD. And most of the people have access to GAD antibodies, I know, across the whole world. And if you are younger patients, you do have a benefit of measuring more than GAD, particularly the I2 and zinc. But if you have older onset of type 1 diabetes, we showed that the incremental benefit of additional antibodies are quite less. So you can still get away with the single antibodies, particularly in this country. What about measuring C-peptide? This is the hormone comes from insulin. We are hormone doctors. We should start measuring this. It's a very cheap test, but it has an amazing ability to pick up people with type 1 diabetes and type 2 diabetes. So this is the data from Exeter, from Rachel Besser when she was with us, and we measured C-peptide in the urine, and we showed that actually type 1 diabetes outside the honeymoon have a ridiculously low level of C-peptide. And you just have to measure once. And they are less than 200 picomoles often, and you can see the type 2 diabetes over there, they are significantly high levels. So you can use this simple test to tell people have type 1 or type 2 diabetes. Now, the things were getting complicated as you've seen by the introduction. The obesity rate is getting higher and higher. So this is the data from America that you can see the nearly 20%, and I think the world is moving towards the 50% of people with obese. And the bottom, I have a data from Pakistan here that within 10 years, the median BMI jumped up 2.3 points of normal people from the national survey. So obesity is on rise and type 2 diabetes is also going up. And so that messes up whole idea that slim and young and old and obese is a type 1 and type 2 diabetes. So that causes a difficulty in diagnosing diabetes. So we need to use biomarkers. So let's just go back to Abil. So Abil had a young onset, slim, so no one, and his mom had type 1 diabetes, so he was treated as type 1 diabetes. Surely that's sensible, I would say. But now I told you that we do need to make biomarkers, so we did measure it. And when we did measure it, turns out he didn't have any antibodies, and he was making loads and loads of his insulin. So he had a significant endogenous insulin secretion. So then we wonder what's next with him. So we did a genetic testing on him, and we found that he's actually got a mutation in a gene called glucokinase. Now, this mutation is a fascinating gene in the human pancreas. So the glucokinase is a pancreas glucose sensor. So if glucokinase phosphorylates glucose to glucose 6-phosphate, so an amount of glucose you have, amount of glycolytic pathway you have, and amount of insulin you generate. So is really the checkpoint of how much insulin you make. And if you don't have or the glucokinase or is the inactivating mutation you have, your glucose goes up. So you need a higher threshold of glucose to make the same amount of insulin. But what fascinating thing about these individuals is that this is regulated glucose. So although it is high, it is perfectly normally regulated in that particular individuals. So the impact of this mutation is that you do not need any treatment, or the treatment has no effect whatsoever. So this is a cross-sectional data as well as a longitudinal data on the people with glucokinase that we have done in Exeter. And on the right-hand side of a panel, we followed the same individuals for 2 years. And you can see that treatment did not change their HbA1c. So some of you are wondering here that, oh, what about the complications? Surely with diabetes, you have to worry about eye disease, you have to worry about kidney disease. Well, we also able to show that these people do not get any more complication than normal people. So they don't get nephropathies and they don't get retinopathies. So it is absolutely fantastic diagnosis to make, because what you can do with what we did with Abil, we stopped his insulin. Not only we stopped his insulin, we also stopped his insulin from a mother. And guess what happened to his HbA1c? Exactly the same. No change whatsoever. And the beauty of this is that you discharge this patient from your clinic. You do not need to see them and tell them you do not have diabetes. Just stay healthy, and you don't need any screening whatsoever for future risk. So what is this fancy type of diabetes I'm talking about? Well, I call them monogenic diabetes. It's a diabetes due to a single gene disease. And normally you can put them in 3 big groups. So the first group is called neonatal diabetes. It's very common, very well known in the pediatric community, but in the adult community, we're probably less aware of it, which is basically anyone who gets diabetes under 6 months of age. So extremely early onset diabetes. A lot of babies get diabetes the first day of birth. those people almost always have a genetic cause. So if you find those people, you do need to do genetic testing on them, and we do it offer free for the lower and middle income countries across the world in Exeter. So you can send those patients to us. The second group, which is called MODY, stands for Maturity Onset Diabetes of Young, is essentially a phenotypic description of young onset diabetes, which is slim but does not require insulin. But turns out that it's a very genetic form, is autosomal dominant, runs in the family, and we know about 11 genes that cause this. And the final, the group that I put them into, is called a syndromic diabetes, which is a diabetes where you have some additional symptoms. Often this is a part of dominant or recessive syndromes, and you might have come across something called Wolfram syndrome. But there are many genes that does the syndromic diabetes. So how common it is? How common should I be worried about? Do I need to look at, are they very rare things? You know, genetic things are very, very rare, and I don't really need to pay attention because I don't have these patients. Well, I can tell you that you all have these patients in your clinic. If you don't have it, that means you're missing them, because we did a very systematic study in Exeter, and we showed that about, in the pediatric population is about 2%, and in the adult population about 4% of people have these genetic forms of diabetes in the clinic. But if you look at it, most of these studies are done in white populations. You know, and we talked about it, how important it is to do the studies in other populations, particularly in Indian subcontinent or our population where there is a high rate of consanguinity. And if you look at the studies already been done, the numbers were really about 50 people studies. It doesn't really inform us what to do about this and how really to find those people from the clinic. So we decided to do something about it. So I went to Wellcome Trust and said, can we have some money? We want to look into this in a population with high rate of consanguinity. And fortunately, we were able to get some money, and we did the study in Turkey in 7 centers, and one of them was Professor Unal's centers. He probably wasn't aware of it, but anyway, I'll show you some data on that. But so we did the parallel studies. We did one in the UK, and we did one in the Turkey. So this is the data from UK. We recruited about 90% of pediatric populations in our locality, and we select some patients for genetic testing, and we found about 2.5% had monogenic diabetes, okay? So not so rare as you might think. Guess what we find when we went to Turkey, which has a higher rate of consanguinity in the population similar to Pakistan? Well, we found exactly the same number. Not statistically it was similar, but the trend was going higher and higher. So what really this tells us that these things are not uncommon as you might think. This is not a problem of white European population. This is a problem across the world. So if they have the same rate of monogenic diabetes, what sort of people do they have? What sort of genetic causes would I see? And that's where the difference lies. And this is called precision medicine, because when you see the different places, you see completely different causes of it. So in Turkey, when we did the study, 41% of cases were recessive. Whereas in the UK, we found almost none. Almost all causes were dominant. So what this really means is that you cannot just simply take the test and send it to an American lab for genetic testing, because American lab would only test for dominant causes. You're going to miss about half of your cases of monogenic diabetes. So you need to be aware that there is a population-wide differences, and you have to pick what genetic test you like to do in those patients. So now I have a second case, and I hope you will realize the importance of biomarkers. So I'll see what we find in the Kabir. So Kabir is got diabetes age 12. He's slim. He's very young, of course. He started as a type 1 diabetes, and I'm sure most of you here would do that as well. If no one wants to do it, please stand up, because I think they need to be retrained. I think you're right to think about type 1 in this case. The HbA1c of 8.5%, and his father and grandmother also had diabetes. Nothing unusual, right? But hopefully, if you take one thing back from today, is that you're going to check what you think. So you think it's type 1 diabetes, so you check biomarkers. So we did. When we did that, turns out his antibodies were negative, which measured his insulin, and he was making loads and loads of insulin. So that's not really type 1 diabetes. And that started another thinking. When you do that, you do the genetic testing, and turns out he had a mutation in a second gene called HNF1 alpha. Now, this is the second most common cause of MODY, by the way. And Andrew Hattersley and Ewan Pearson in Exeter did a first ever precision medicine trial in any form of medicine back in 2003 and showed that actually these individuals respond 4 times more to sulfonylureas to metformin compared to type 2 diabetes. So therefore, this individual needs to be treated by low dose of sulfonylureas. You start with generally 20 milligrams and work your way up. And when you do that, you actually can stop insulin in about 70% of cases, depending upon how long the diabetes they had. So let's go back to Kabir. So Kabir was on insulin. We stopped it, insulin. And we put him on a gliclazide, 40 milligram, and his HbA1c was 6.5%. So this is the power of doing a classification on the patient you have with diabetes. Do not just assume what they have. Please proactively go and look for the cause for it. So how do I do it? Now, I know you may be thinking this is a guy from UK and just talking fancy things about it. I do not have these people in my clinic. I tell you that because I'm very vigilant clinicians. I can tell you a lot of, we're missing 77% of monogenic diabetes in the UK. So we are bad. So I'm sure this is a universal problem. So what tips I can give it to you to pick those people up? Well, the first tip is that there is no precise cutoff you can use. Their age of diagnosis, BMI, HbA1c, and the parental history of diabetes all overlapping between type 1, type 2, and monogenic diabetes. So I'm not going to give you one single cutoff to say, if your patient have this, they have monogenic diabetes. No, they don't. So what you need is some intelligent way to put this together. And I have a very simple tool because I don't want you to remember all of this because you will not. So instead, I suggest you use this app. So we have created this called MODI probability calculator. Bev Shill did a few years ago, and this is now updated for South Asian ancestry. So we will we'll able to use across Pakistan and Indian subcontinent. And all it requires is some simple clinical information that is available in front of you there and then. So then it gives a probability of MODI while patient is sitting in front of you. So please use it. So once you find those individuals, normally we would say that if his probability is more than 25%, you should consider genetic testing, but I've done some analysis on South Asian populations, and I'm not going to show you to data, but actually you need to go slightly higher probability before you consider genetic testing. But once you have that patient in front of you, the next thing you need to do, you need to have a 2 rule-out test. The first test, you need to do the C-peptide. Because C-peptide will tell you amount of insulin they are making. If the C-peptide is significantly low, I think you just say this is type 1 diabetes, and I'm not going to bother, because we showed that compared to type 1, the MODI had a significantly high insulin secretion. So, simple rule-out test costs in the UK is only £10, and I'm sure it is commonly done here as well. But that will tell out outside the honeymoon, you will be able to rule out test 1. Rule out test 2 is the Islet autoantibodies. So you need to do that if you suspect someone, and it will help in about 90% of cases because antibodies are negative in 10% of type 1. But at least it gives you, rules out most of the type 1 diabetes. If you have a positive antibodies, it's virtually unlikely, or 1 in 5,000 chance. If you have 1 antibodies and 2 antibodies, is 1 in 1 million chance of MODI. So you're not going to miss many MODI if you use that probability. But you just realize that I'm only talking about the dominant causes. Although I've just showed you that half of the causes here are recessive. So what can I tell you to pick those recessive causes? Is there any simple tip I can give you? Well, actually, yes, there is. So let me show you what you can do right now to pick those recessive cases that we have all in our clinic. So if you imagine this, there are classical criteria. So this is the data from Turkish study just to show you that the classical criteria still does work in our population. So so parents with diabetes, non-insulin treatment, lower HbA1c, and high MODI probability will pick up those dominant causes. But it will not pick up the recessive causes. These causes will not be picked up. So you will miss those ones if you only use this. So we proposed the new criteria back in a couple of years ago, and the paper is out there, that actually, if you do want to pick up the recessive causes, all you need to do is to ask one question. Does my patient have non-autoimmune additional symptoms? And that's all you need to ask. If the answer is yes, then the chances of them having a recessive cause is about 80 times more than type 1 diabetes. So that's all you need to ask. And do the parents are consanguineous? Then yes. If you answer the yes to both of those questions, I think you need to start thinking beyond type 1 diabetes. And then you need to exclude type 1 diabetes, of course, doing the biomarkers as we discussed. So this is the take-home message from myself, that if you do suspect people with diabetes, with type 1 or type 2, do use biomarkers. Antibodies and C-peptide, they are your friends. Don't be afraid. Do it more. If they are antibody negative and additional autoimmune symptoms, I think you need to consider genetic testing, and we do it offer free in Exeter, so do feel free to email me. And if they have isolated diabetes and antibody negative, use the MODI probability calculator. It is available free of charge, and you can use it. And finally, if you do want genetic testing, make sure you use the lab which offers both dominant and the recessive causes. So I'd like to thank my funders. We've been very fortunate to be supported by Wellcome Trust for many years, and Diabetes UK, JDRF, and my mentor, Professor Andrew Hattersley, and the fantastic thing that we have in Exeter working on this. So finally, I'm going to stop by showing a bit more slide that you can, how you get genetic testing done if you wanted it. So at the moment, we have funding from Wellcome Trust to do genetic testing for people who got diabetes and additional features. That's my number, that's my email. I will not bite. I'm very friendly, so you can email me and text me if you have those patients. All you need to do is to send the sample to me, and we will do testing for all types of diabetes for you. So thank you very much, and I'm happy to answer any questions. I'm around this afternoon, so if you have any patients you want to chat to me, I'll be happy to help. Thank you.
Thank you so much, Dr. Kashyap Patel from Exeter Medical School, UK. The house is open for question and answers. Because of time constraint, we can take only few. Okay, sir. Mike.
Thank you for a wonderful presentation. I really enjoyed it. And regarding the two cases you described, the first one, you said you took them off from insulin. That is understandable.
Yes.
And you said you can take them off from
That's correct.
because they don't work, that I can also buy. But what I don't understand, that you said they would remain hyperglycemic,
Yes,
but will not develop any
That's correct.
hyperglycemia-related complication.
that's right.
That is in contradiction with all the other data which we know from UKPDS and DCCT.
That's correct.
How can you explain this
Absolutely,
disparity?
absolutely fantastic question. So, I'm telling at the same time these people have diabetes, but what happens with the glucokinase MODI is actually their HbA1c is tightly clamped between 5.5 and 7.5. So only half of those people actually have HbA1c more than 6.5. And the fact that they don't get complication is because their HbA1c on average is very low, it's around 6.5, and also the glycemic variability is extremely flat. If I show you the glucose profile of those individuals, they are like literally straight line. So because of the low exposure of glucose, not as high as type 2 diabetes, the complication rates are very low. So we actually studied the grandparents of those individuals who's been living this for 90 years, and none of them had any eye disease whatsoever or nephropathies. So I think it's because of the lower glucose and physiologically regulated with a very, very high CV means the complication rates are low.
Any other question?
Thank you, Kash, for such a wonderful talk. We know we do have Moody's here. There's no doubt about it, and different forms of Moody's. Are there any ongoing work, or in your experience, where GLP-1 agonists have been used for Moody's? Because they are usually obese, and one would like them to lose weight.
Yes.
They have insulin sensitivity
right.
problems, and of course, in
Yes.
algorithm of type 2 diabetes, GLP
Comes
is
slightly
used
early.
much before
That's right.
insulin.
That's right.
Right.
So the question is, the people with HNF1 alpha and HNF4 alpha moody, they are highly sensitive to sulfonylurea. Is there any options of using other agents? And I think it's a very good question. So Tina Visbol in Denmark did the studies on that and used the DPP4 inhibitor as well as